It's a rather difficult pivot when you get to be the cheerleader on technology, but in a way, all of the things that you've heard from patients and patient advocates this morning is why we are all in medicine. It's why we're making new things, and it is why we strive to provide care the best that we can. And while it's disappointing to hear a lot of the failures that have happened in medicine, that's the sort of thing that makes us keep trying and makes us continue to look for new ways of doing things. And yes, I'm also a geek. My way of trying to fix things is often to try to bring technology into it. How can we make something a little bit, how can we make it work better? How can we make it work more smoothly? And so I'm going to talk a bit about a technological area that I know the most about in the area of surgical robotics, but really to use it as an example of how we ought to think about how we try to bring technology into healthcare in general. So there will be some surgical pictures. I figure you're all in healthcare, you can handle it. Because this image should shock you. We can do all kinds of amazing surgery. We can open up the body, we can replumb it, we can take tumors out. But the incision serves no therapeutic value. It's inefficient. It causes most of the pain associated with the surgery that people have. And so an excellent technology was invented in the 1980s. And it became available really because of large technological advancements in fields totally unrelated to medicine. These advancements were in the area of very small CCD cameras and a lot of being able to put rod lenses and things like that into the body. And this is laparoscopy, or keyhole surgery, where you take a long instrument, you place it through a very small incision, and then you can work through that small incision and do the surgery that you would do through that large incision on the other side of that small incision. And the big idea is that big incisions can become small incisions, and the same therapy that you need to do on the inside can still be done. In the 1980s, this technology came out. And it was very rapidly adopted in some areas. That little tall one here is cholecystectomies, the removal of the gallbladder. So by the early 1990s, almost 90% of these were being done laparoscopically. But you'll notice something very dramatic, that as the surgeries got more and more complex, the ability of people to do it minimally invasively fell off. Patients would not be offered a minimally invasive surgery if their surgeries were too complex. So like good entrepreneurs and business people, with a new technology in hand, this was seen as an opportunity. How could you bring minimally invasive surgery in an area where it wasn't? And so this is the Da Vinci, this is the business end. It's essentially a surgical instrument that has the dexterity of the hand and wrist that you can put through a very small incision. And the motions of, it is not a robot that does surgery. It is a tool. The surgeon's hand makes a motion, and those little metal surrogate hands follow every motion that that surgeon's hand makes. So you can repair a heart valve from the inside of the heart without cracking open the sternum. You can do all sorts of abdominal, transoral surgeries without having to make a large incision. And so there are a lot of very fancy, high-tech, and yes, somewhat expensive instruments that are able to take this surrogate surgeon's hand and put it on the other side of that small incision. And the goal was to do exactly the same surgery that was being done open, but now through small incisions. And I'm going to argue that that's not a good enough goal, because we've been doing surgery for a very, very long time. These are surgical instruments that were unearthed from Pompeii. and you clean the rust off of them, and they wouldn't look that out of place on a laparotomy tray today. The idea that we were doing exactly the same surgery on the inside isn't really enough of a goal. And as an example of why, this is a staging chart for lung cancer. How bad it is when you are diagnosed at different levels of size of tumor and whether it's crossed over. So if you're diagnosed at stage 1A, still smaller than 2 centimeters, you have a 77% chance of seeing your 5-year anniversary, which is sort of the gold standard for have we done good cancer care. 1B, where it's now in the 5 to 7 centimeter range, you've got a 58% chance. Drops to even odds if you're getting up to the 7 centimeter and you're starting to get local spread. 35% chance of seeing that 5-year anniversary if you're starting to get crossing over. And an 11% chance if you have distant metastases, if the lung cancer's moved outside of the lungs. Worldwide, the average is 15% survival at 5 years. And that means we are not catching it at stage 1A and stage 1B and stage 2. We are catching it somewhere between stage 3 and stage 4. And I can't do anything about that with my fancy robot. I can take the portion of the lung that is diseased, but I cannot materially affect the outcome for that patient. And so I start to think of the robot as more of a technology platform. The modest saying of the company is taking surgery beyond the limits of the human hand. And there's a lot of very exciting things that we can do. There are clinically relevant things to do that are beyond the scale of what the human hand can do. On the left is a retina, picture of the retina, and the vessels on the back of your retina, which are crucial for sight, are about 30 microns in diameter. A well-trained surgeon's hand can operate with about 100 microns of precision. So if you've got a shower of clots into the retina, you will lose sight to that portion of the eye unless you can open up that vessel, take the clot out, inject a clot-busting drug, something like that, and then be able to pull back from that. We have a lot of things that we think of as being ourselves, our sight, our hearing, our taste, all of our senses, and most of our ability to operate on those senses are at scales that are below what the human hand can actually do. On the right is a picture of a blastocyst with a hole being drilled in it with a femtosecond laser. The femtosecond pulse is so fast that you don't heat up any of the cells to either side. So if you can tell which cells are bad and which cells are good, you can say, bad cell, drill a hole in it. Good cell, I'll leave it behind. And you can start to think in terms of, if we can diagnose cancers at very early stages, unwinding a cancer from around a neurovascular bundle. You start to be able to think about doing surgery on this really, really small scale. But to do that, we have to take surgical technologies beyond other senses, not just the size of a scale. This is the sense of smell. This is a dog's nose. Dogs have been trained to detect cancer on the breath. It was not known what the biomarkers in the expelled breath were, but you could train dogs on these people have cancer, these people don't, and then they were pretty good at detecting the breath, cancer on the breath of later patients. You had an existence proof that there was something in that biochemical soup that was pathognomonic for cancer. And sure enough, there are now companies out there trying to bring technologies such as field asymmetric ion mobility spectrometry into the world of medicine. This technology came out of bomb sniffing. How do you find the small organic molecule signature of explosives in the field of dilutants that are out there? It's the same problem you're trying to solve in healthcare. And we continue to borrow technologies that are coming out of other areas. because we need to take our senses beyond sight. This is a kidney cancer surgery. If you put in a fluorescence dye that can go wherever the blood goes, you can see where the blood flow is in the body in real time, in surgery, without any radiation. This is pure reflected light fluorescence in the near infrared. We like near infrared because we're very transparent to near infrared. This is useful in that you can clamp off individual vessels and you can see whether you have cut off blood flow to the portion of the kidney that has a tumor in it. And that can be very useful. More exciting for me, though, are in areas where we can make targeted molecules. In this case, we've put a fluorescent molecule on a folate receptor that binds to ovarian cancer. Now, ovarian cancer spreads within the peritoneum very rapidly. It is almost metastatic long before it's metastatic because it will spread by local spread, but it will spread all over. And so it's generally not considered a surgically treatable disease by the time it's clinically detectable. But if you can light it up, now you've got enormous contrast. It lights up like starry night. Now you start to be able to say, can we do this surgery in such a way that means we can get every little part of it? Can we turn this death sentence into a surgically treatable disease? We're also thinking in terms of technology of taking it beyond the human brain. We generate so much data. We are pattern matchers. As clinicians, that's what we're trained to do. We're trained to look at a CT scan or trained to look at an operative field and be able to pattern match with what we expect it to be. But as we start to think in terms of big data, as we start to bring in things like the IBM Watson and deep learning, we start to be able to sift through these enormous data streams, these very data-poor data streams. One of the things that you heard over and over again, and we talked a little bit about this at lunch, but from the consumer advocates, is crucial pieces of diagnostic information were buried deep in their medical records that were probably about this thick. And it took someone really dedicated to sift through all the dross that was in there to find those really important things that were missed. And so when we think about medicine as only generating more and more data, and our practitioners having less and less time to be able to sift through all of that low-quality data to find those few really high-quality nuggets, these are the sorts of tools that we start thinking about bringing in. Now I'm super excited about it because we're looking at the ways in which people learn how to do surgery and being able to see their path through this. But we're also using it to sift through all the different kinds of data for genomes and being able to figure out, is this the right treatment for this individual person? Or being able to take their tumor and do real-time tissue diagnosis as we're looking at it. I mentioned we're also learning how people learn, because we've never been able to fully digitize surgery. It's a psychomotor skill. We teach it by the apprenticeship model. Have I shown you how I do it? Let me watch you do it. We can now actually look at all of the motions that people are making and what it was that they saw, and can we do image recognition, and can we figure out how they are acquiring this skill, and can we see what kinds of mistakes they're making and be able to help them acquire this skill more quickly. And so I think of robotics, in my case, as a platform onto which we bring all of these other different sorts of technologies that in a lot of ways let us give surgeons superpowers. And that's a very tempting spot to finish a talk like this, because everything's great. We have all these wonderful new technologies, we're bringing them onto robots, we're going to be able to make everything good in the future. But that's not really the only story, because we can promise a lot of these things. We can look at these things and we can say, yeah, it makes sense to me that if I were to have that capability, I would be able to materially affect patient outcomes. But how do you know? Because you can't manage what you don't measure, and you have to ask those questions appropriately so that you are measuring the right things. And then there's that pesky thing called evidence. How do we know we are doing the right thing? Because when the Da Vinci was first adopted, when any new technology is first adopted, there is no evidence. Not the way we think of evidence in terms of 5 years of follow-on cancer data or a randomized control trial, which is almost impossible to do in surgery because it's operator dependent. A pill works the same no matter how you who it is that hands that pill to you, but the surgery is not the same. And so these are very, very difficult sorts of things. And so it was bought on the idea that big incisions are bad and small incisions are good. And so let's talk about evidence. FDA clearance in 2001. If you think about it, and you put your epidemiologist hat on, the first time you're going to be able to see the first publications of just even case studies, we're probably looking, you've gathered enough data out here. And you'll notice that you still don't even have that many cases being done. You didn't even get to 4% of the cases being done robotically until a couple of years that were coming later. So you have a bulk of cases probably 2 years later. Add 5 years to that for 5-year cancer survival, and we're now out here. Almost 50% of the procedures were already being done with a Da Vinci robot in the United States before the first cancer evidence could ever have been there. Now, so if you'd waited for the cancer evidence, what would you would have gotten a few cases out here, you would have waited, and then there would have been an adoption. But this is one of the fundamental problems that a lot of HTAs are struggling with right now, is how do you bring a new technology in? Do you do an adoption with evidence, meaning you adopt it at the beginning, and then you gather all of your data to see how it affects a population? Or do you wait for some other healthcare system to do all of that data, and then you follow along? One of the things that's going on with the Affordable Care Act in the United States, and which is causing a lot of HTAs around the world to start pulling their hair out, is the United States isn't going to be out in front anymore in terms of the traditional fast adoption that it's done. And so, because the United States is going to be hanging back and waiting for evidence as well. But what happened, and this is a very fast adoption of technology, is that it probably would have died. It probably would have died around here if the data came in and said that it wasn't helping. And it's been fascinating from the point of view of someone who training in statistics. My mom's a biostatistician, my dad's an epidemiologist, both trained at Otago, that lots of people continue to say that there is no evidence. And you've got to wonder, what is evidence then? Right now, there's over 7,000 peer-reviewed journal articles in the area of robotic surgery that have been published since it started getting adopted without evidence. This is sort of an internal report that I've stuck on here, which is, I keep hitting the wrong bits. I'm going to go one more back. That is, this was the 180 publications from January 2016. So we get I don't read all of these articles, but they're generally classified by level of evidence. And systematic reviews, RCTs, systematic comparison studies, including single-arm studies, retrospective non-randomized, literature reviews of single-arm studies, and level 5, case reports, animal, cadaver, bench studies, and editorials. If you look, a majority of the papers are coming out at this level 5, which I think is a problem with our academic system, in that tenure committees can count, but they can't read. And so they make sure that you publish as much as you can, but they don't actually have to be high-quality studies. So while there's 7,000 plus peer-reviewed journal articles, most of them are crap. Not to put too fine a point on it. But there are some high-quality studies that are out there. But this is the dilemma that every new technology faces, in that there will always be a significant evidence delay. This is not confined to robotics. This is just the one that I'm paying attention to. But when the data do come out, there is a significant difference in terms of outcomes compared to open surgery. And it's also tempting to compare it to laparoscopy, but at its peak, only 4% of prostate cancer surgeries were being done laparoscopically. 96% of them were being done open. And today, 90% of the prostate cancer surgeries are being done minimally invasively with robotic help. All of this outcome difference is entirely on that incision. Because most of these those other fancy technologies I talked about were not involved, haven't been available until fairly recently. We saw the same shift happen with hysterectomy in the United States, where at peak it was about 15% being done minimally invasively, and today it's over 75% being done minimally invasively. So laparoscopy isn't, you have to pick the correct comparator. Even in cases where there was significant laparoscopic penetration, in the case of benign hysterectomy, we saw laparoscopy go up in response to robotic introduction. And what we saw come down was open surgery. And no one quite knew what this effect was, but what it turned out to be was the laparoscopists in the hospitals upped their game and were trying more complex laparoscopy surgeries when robots showed up. And so you saw opens drop precipitously in hospitals. And that was primarily, again, these are issues, this is compared to open with just the incision. And so now there's about 3,500 robots in 30 countries. And so now the next question has to be asked. Is it worth it? You may accept that it gives you a better clinical outcome, but does it cost too much? And so part of the problem is the way technology gets adopted, especially in the United States. So you have two competing hospitals, and they're competing for patients, and some cool new technology comes out in the form of a surgical robot, and that hospital advertises and says, all you patients come to me because I've got the coolest new technology, and all the patients flood to this cool new technology. The other hospital says, I have to buy one to keep up. A couple more patients come back, and then pretty soon there's an arms race, and everybody has this technology. And it's redistributed, and what have we done? We may have only just added cost. But we saw some very interesting things happen also when we looked at our own data. And that was that many hospitals bought second, third, and in some cases even fifth systems. And they tended to be the kinds of hospitals that were extremely vertically integrated, the Kaiser systems of the world. When you talk to their CFOs, they were playing a very different game. They were looking across the entirety of their healthcare system, and they were saying, if I can get people through postoperative beds in 2 days instead of 5 days, I've doubled my postoperative bed capacity without building any more bricks and mortar hospital. So they're saying I put a $2 million robot in, and I don't have to build a $1 million per bed wing. And so so the question is, how were they slicing and dicing the money that they were doing? And so again, also, the more vertically integrated the hospital system was, the more likely they were on the hook for downstream complications. And so the more heavily invested they were in minimally invasive technologies of all kinds, because they were saving money in the long-term care. So lots of studies have been published on the cost of robotic surgery. So in a heart study, $7,218 per case more than doing it open. In a cystectomy study, $4,846 less, $6,587 more, $3,894 less. New England Journal of Medicine published an opinion piece which said that robotics, if it were widely adopted, would cost Medicare $2.5 billion. And in Health Affairs, there was a study that said, if you adopt robotics universally, in kidney cancer alone, Medicare will save $2.5 billion. And so you look at all of these contradictory studies and you say, what's right? And the answer is they are all right. Every single one of those studies is correct. It's what you're measuring. And they're all measuring them in very, very different ways. So what's fascinating about that heart study is they bought an expensive robot and they barely used it. They only used it for 50 cases a year. And so they amortized a $1.5 million robot over 50 cases a year. So of course it cost them an enormous amount of money. The next one, they looked at all of the long-term complications of a very complex procedure. And they discovered that the long-term hospitalization and the complications of those cancer patients, of the bladder cancer patients, so overwhelmed the cost of the technology of how they were bringing out that they were saving a considerable amount of money with each case. In the GYN one, the 6,587, they did a study based on charges. We charge $6,500 more to the patient for a robotic cancer, for a robotic surgery. Now, for those who work in the wonky world of the differences between costs and charges, you can do certain things like cost to charge ratios, but unless they're the same all the way throughout your hospital, they're absolutely meaningless. So essentially, they did a big paper that they published on this is the difference between what we charge different kinds of patients. The Medicare one for the $2.5 billion increase, they were assuming, if we assume $3,000 more per procedure, and we assume that it replaces a whole bunch of laparoscopic procedures that it would have otherwise done, then Medicare, it will cost Medicare this much more. And the one at the bottom, the $2.5 billion saved, was they did a study where they looked at the rate of partial nephrectomy versus total nephrectomy. And they found that partial nephrectomy increased by a factor of 50% in hospitals that had the robots. And if you take the entire kidney out, when you could have only taken a portion of the kidney out, long term, that person is much more likely to end up on dialysis. And so they looked at the total cost of care. So it's a little disingenuous because that $2.5 billion that they're saving, some of it they're saving about 20 years down the road. But every single one of those studies was done with an appropriate methodology for what it was that they were trying to measure. And so you go up to a place like Canada, and they want to do a study where they're saying, okay, if we do look at this from a multi-specialty point of view, how many procedures per year do we have to do before we start to break even? Because they're amortizing their robot. And they discovered that in a multi-specialty, if they were doing about 300, for some reason their prostatectomies were not as cost effective, but their nephrectomies and their hysterectomies were very much so. And they found that if they were in about a 300 case per year, after that, they started saving money over what their other costs would have been. You pop over to Sweden, and a fascinating study got done where in the Nordic countries, time off work is paid for by the healthcare system, which for those who are in the Ministry of Health probably sounds like a nightmare, because so instead of the company that the person works for, it's part of your total medical care. And so they were very interested in how long it took people to get back to work. And so they found if they had minimally invasive surgery, they were back after 11 days. And if they had open surgery, they were going back after 7 weeks. So they measured what they cared about, and they have some of the highest adoption rates of robotic surgery of any countries in the world because of the way they pay for things. Doesn't matter to you if you don't pay for it that way. That's not, it's the wrong study to do. In the UK, they did something very similar to what happened in Canada, and they realized that unless you use your robots like crazy, they're not cost effective. And so they're in a few hospitals, and everybody has to go to those hospitals. A hospital cannot get a robot in the UK unless it can guarantee more than 250 cases a year. In Germany, private insurance noticed that if they end up spending less overall on the patients who had minimally invasive surgery, who had robotic surgery. And so they split the difference with the hospitals and added a 1,500 euro bonus if the procedure got done robotically. And this was just a random actuarial table that an insurance company did and started doing this kind of incentive. India, you might be surprised to know that there's actually quite a few robots in India. And I was talking to a surgeon there who said, it's really unconscionable. I have to pass on the 1.5 lakh rupee cost of the instruments to the patients. You need to make less expensive instruments. And I said, yes, we do need to make less expensive instruments. Why does someone pay 1.5 lakh rupees? So that ends up being about $2,000. And she said, because there's no social safety net. There is no time off work. You do not get paid when you are off work. And so for the patient, it's actually worth it to pay that surcharge because then they can get back to work that much faster. And so this is one snapshot into how no two countries that I've looked at here value these things the same way, are measuring it the same way, and how wildly different your assessment of the value of a particular technology is depending on what it matters to you. And it may or may not make sense in New Zealand. In a lot of ways, the volumes are very difficult to achieve the way the hospital systems are set up here. So these sorts of things, you have to measure what matters in your healthcare system. And it may surprise you what is expensive and what is not so expensive. The other thing, so this is a pop quiz. I know it's not fair. Right after lunch, everybody's a little bit sleepy. Does anybody, geeks particularly challenged in the room, know what this is? It's the first transistor out of Bell Labs, 1947. They were trying to make a little amplifier. They had no idea what it was that they would be unleashing with this. And to give you an idea, 1947, so my dad is probably around 10 years old at this point. And this is what a radio and a mobile phone and a code cracking computer looks like in 1947. Fast forward to 1979 when I'm around 10 years old, and you probably remember the Walkman, and I'm cheating a little on the cell phone. Cell phones actually came out a couple of years later, but this is what the prototypes were looking like in 79. And then you have computers bifurcating into the sort of the personal computers and the really big computers. I have a 12-year-old daughter, and this is what a music player, a computer, and a phone looks like to her. All of these things are tied up in one. And what makes this technology so revolutionary, and what makes it disrupting actually every aspect of the things that we're doing, is this. We take all of the capabilities of all of those things and we put them on one device and we stick it in our pocket. And you couldn't see where that was going to go even in the early 1980s. And so when we think about a lot of these technologies, they will be ugly when they come out the first time round. They'll be expensive when they come out the first time round. But they will end up being very disruptive if we figure out how to measure their efficacy. And we figure out how we ask the right questions about them, because you have to ask the questions that are relevant for your system. So this is the way I look at the future. And I'm trying to keep a lot of my eye on lots of technologies that are in adjacent fields, trying to figure out how they're going to come in, how we can bring them in, how they're going to disrupt what it is that we're doing. Thinking about ways in which we can improve workflow. We can take things like a non-therapeutic incision and get rid of it. How we can do things like take that pattern matching judgment of this looks like cancer and make it glow so that it absolutely is cancer, and figure out, in the end, how we serve the patients better. So with that, I'll open it to questions.